My name is Bill Bullman. I'm one of the associate professors of medicine in the Department of Medicine, and I am one of the pulmonologists here. I'm the co-course director for the pulmonary section along with Dr. Amy Atkinson, who's here. You'll hear her speak later in the week. I want to welcome you to the pulmonary section. This is the email addresses for both Amy and myself. We want you over the next 2 weeks to feel absolutely free to email us with questions, with comments. If anything in any of our lectures or the other speakers' lectures are unclear and you'd like us to elaborate on them, we can either do that in the lecture hall the next day or with an email back to you. Just first of all, I have no disclosures. I'm going to give you just a very brief overview of the pulmonary section and then do a 50-minute lecture on just an introduction to the core concepts in pulmonary medicine and an introduction to how we clinically approach the pulmonary patient. The first objective of the course as a whole is to understand the normal structure and function of the respiratory system and the lungs, and also to provide an understanding of the various structural and functional abnormalities that lead to pulmonary disease. We're going to also introduce a wide variety of diagnostic tests used in evaluating patients with potential pulmonary disease. And then just today, we're going to go over some of the very basic management strategies for some of those diseases. And you'll be introduced over the course of the next 2 weeks to a variety of diseases. The course itself has 21 lectures. There's going to be 4 team-based learning sessions. There's 3 path sections. Dr. Alan Borshuk is the director of lung pathology here. He's going to be doing a number of lectures in histology and pathology. The core textbooks for this course are the ones you've been using all along. Costanza is actually great. Robbins and Larson are excellent as well. We're going to be introducing some suggested readings and then some required readings for the TBLs over the course of the 2 weeks. And then as people go along, I think there's some suggested readings that come up in each of the lectures if anyone has a particular interest in an area or wants to go more in depth or has a future in pulmonary medicine. Your responsibilities are pretty simple. You have to be present, you have to prepare, and we ask you to participate. The present part, I think, is the most optional out of all of those. But we encourage you to come to the lectures. Our lecturers put a lot of time and a lot of effort, and some of them are actually quite entertaining. So I think it's worth coming and seeing people speak on these topics in person. Ooh, sorry. Okay. We're going to talk about anatomy, embryology, and histology in the sort of health section, and the principles of pulmonary physiology, air and gas flow, gas exchange, and ventilation and perfusion matching. I'm going to introduce these concepts. The last 3, the physiologic concepts, you're going to get a total of 4 lectures on those 3 concepts. Some of them are quite nuanced and difficult to understand, and understanding the physiology of the normal respiratory system is absolutely critical in understanding how and why disease develops. We're going to talk over the course of the 2 weeks about diseases of the airways of the lungs, the lung tissue itself, what we call the lung parenchyma. We're going to talk about the concept of respiratory failure in detail and the different ways in which the lungs can fail. We're going to talk about diseases of the pleura. I give a lecture on that later in the course. We're going to have a lecture on the pulmonary vascular diseases. It's Amy's area of expertise, sleep disorder breathing, obstructive sleep apnea, and a wide variety of diseases of the respiratory system that occur during sleep. And then we're going to have a really great lecture that's new this year on the global impact of lung disease being given by Dr. Neil Schluger, who's our division director. All right, so I'm going to talk for the next 45 minutes or so about the very basic anatomy of the respiratory system. I'm going to introduce those core concepts of gas flow, gas exchange, and ventilation perfusion matching. And then I'm going to give you just a very brief introduction on the clinical approach to the pulmonary patient. Over the course of this lecture and the subsequent lectures, we'll try and point out some of the things that are more testable. This lecture, if there's anything here that doesn't make sense to you, it's probably because it's going to be introduced in much greater detail later in the course. So. This is just a cartoon of the respiratory system as a reminder that the respiratory system is much more than just the lungs. We have the lungs and the conducting airways, the trachea and the bronchi, as what we call the lower airway. But we also have the upper airway, which has very, very important function of conducting gas, atmospheric gas, down into the lower airway, but also warming it and humidifying it. And then we have the very important component, the chest wall and the respiratory muscles, which I'll spend just a few moments discussing. The main respiratory muscle that we all think of is the diaphragm. It's a fairly complex dome structure that when it contracts moves downward and flattens. But we have other respiratory muscles as well that are very, very important. The muscles of inspiration, aside from the diaphragm, include the intercostal muscles. The intercostal muscles, when they contract, move the upper ribs sort of outward and up, and move the lower ribs outward and laterally. And the consequence of that is to increase intrathoracic volume. This is a cartoon from my anatomy textbook back in the 1980s, showing what's called the pump handle movement of the upper ribs and the bucket handle movement of the lower ribs that sort of increases intrathoracic diameter and the AP diameter and the transverse diameter. And that, along with downward movement of the diaphragm, increases the volume in the chest, causing negative intrathoracic pressure and air to be drawn in from the atmosphere. The muscles of expiration, for the most part, in normal, relaxed breathing, are very passive. It's the elastic recoil of the lungs that allows the air to leave the chest in normal, relaxed breathing. But we don't always just do normal, relaxed breathing. If we're doing labored breathing, breathing with increased demand, or breathing that's very forceful for a variety of different reasons, we have a whole host of new muscles that come into play. There's the accessory muscles of respiration, the muscles in the neck, the sternocleidomastoid muscles. And then there's accessory muscles of expiration, forced expiration. Your body will bring in abdominal muscles and the internal intercostal muscles. You can look for, and I'll talk about it in just a few slides, movement of these muscles to get a sign that a patient's having labored breathing instead of just relaxed breathing, or is working hard to breathe. That change in intrathoracic volume caused by movement of the ribs is shown in this expiratory and inspiratory chest X-ray. On the right, that red arrow shows where the seventh rib is, and you can see it's moved up. You can see the whole, at least in this view, transverse diameter of the chest is increased. The diaphragms have flattened out a little bit, and that's a normal inspiration. The lungs themselves, we have two of them. There are 3 lobes to the right lung, 2 lobes to the left lung. This is the lungs looking at a lateral view. This is the anterior section of the left lung. This is the anterior section of the right lung. And you can see that the lobes don't sit stacked one on top of each other, but they basically sit, at least on the left, one in front of each other. The upper lobe on the right side sits on top the middle lobe, and the lower lobe on the right side tucks up behind the middle lobe. All of these lines in between the lobes we call fissures. Picture this anatomy when we go back and look at some normal chest X-rays, and you can see when you're looking at the chest, looking at the lungs through the chest with plain X-ray, you can see that some of these structures obviously will overlap each other. This is a bronchoscopic view showing the distal trachea. You can see that the trachea splits into 2 main stem bronchi. That's the left, that's the right main stem bronchus. There's cartilaginous support of the large and small airways going down to very, very small airways. There's no cartilage at the back of the trachea. This we call the flat membranous, posterior membranous trachea. But this cartilaginous structural support extends down into airways that are as small as several millimeters and help hold the airways open, particularly in expiratory airflow in healthy, normal people. This is a schematic showing that the airways from the trachea down to the alveoli actually branch many, many times. The typical person has somewhere between 20 and 25 generations of these branching, this branching fractal tree. This results in a natural division of airways that conduct gas down to the sort of business end of the lungs, the alveoli. We start to see alveolar outpouching on what are called the respiratory bronchioles, but ultimately these lead down after several generations of branching down to the alveolar acinus, and I'll explain what that is and show you that in just a slide or two. It turns out that if, and someone did this, if you add up all of the airways that a normal healthy person has in their lung, there's something in the way of 1,500 miles of airway, most of it obviously microscopic, and somewhere in the neighborhood of 300 to 500 million alveoli in a healthy person. The function of those conducting airways and the alveolar units are basically ventilation and gas exchange. And these are not separate things. These are very intimately related things. Ventilation is the supply of fresh oxygen down to the alveolus. Gas exchange is obviously oxygen coming in to the bloodstream, carbon dioxide going out, but we gauge ventilation by measuring the efficiency of carbon dioxide. Very intimately interrelated concepts. And again, you'll hear an entire lecture about each of these things over the next 2 days. So basically, we have gas exchange occurring and ventilation occurring, but they're very intimately interrelated. This is 2 different types of electron micrographs showing what the alveoli look like. On the left is a silicone cast of a collection of alveoli that belong to one single, we call them terminal bronchioles, but basically the last airway before we start to see alveoli. And you can see there's many thousands of them clustered around a single terminal bronchiole. And the scanning electron micrograph at the right just shows at a much finer detail that the alveolus is actually a little bubble. We call this thing on the left the acinar unit. Acinus is, I think, Latin for berry. It looks like a cluster of grapes. And not to be repetitive, but basically this is the function of that unit to get oxygen into the bloodstream onto the carrying units, the hemoglobin molecules in red cells, and to get carbon dioxide out. The distensibility of the lung and the corresponding elastic recoil of the lung is a function of elastin. These are fibers that are present in great abundance. This is a regular photomicrograph, and elastin in this case is staining a gold and yellow brown. There's lots of elastin in the interstitium, the space between these alveoli. When we put all of these various units together, we get basically the respiratory system, which, as I said, involves much more than lungs. We have the signal originating for a single breath in the respiratory center in the medulla. It's conducted down the phrenic nerves, the right and left phrenic nerve, and that activates the diaphragm. You have activation of the intercostal muscles. You have a change in interthoracic volume and atmospheric air being drawn in all the way down to those alveoli. You have passive respiration causing a change in interthoracic pressure for the positive to allow air to allow gas to come out, and gas exchange is happening down below here at the level of the alveoli. This very nice series of descriptive cartoons leaves out an incredibly important element in the respiratory system, and that's the vascular component of the anatomy. You actually have 2 of them. There's the bronchial artery circulation, which is relatively insignificant. It is systemic blood coming off the aorta. These vessels go through, the bronchial artery vessels go through the interlobular septa and go out to the visceral pleura. The insignificance of this in terms of respiratory physiology is highlighted by the fact when we do a lung transplant and we cut someone's old lungs out and put someone's new lungs in, they don't even bother to hook up the bronchial artery circulation in the majority of patients. They just leave it out. And those people breathe and exchange gas absolutely fine. The real business end of this is the pulmonary arterial circulation. Basically, the right heart pumping the entire cardiac output in a much lower pressure system, lower resistance system, out to the capillary bed where gas exchange takes place. And that's really, when we talk about the pulmonary arterial circulation and the diseases of the pulmonary arterial circulation, that's what we're talking about. So essentially, what your body has set up, and the mammalian body has set up, is this series of branching, or these two branching systems that branch together in this fractal pattern all the way down to the microscopic alveoli, and all the way down to the microscopic pulmonary capillaries, and they are interfaced in this very, very intimate microscopic way. You're basically in this system every single minute pumping 5 to 8 liters of air in and out, pumping 5 to 8 liters of blood through your pulmonary arterial circulation, and your body is matching them very, very, very closely. We refer to these two systems as ventilation and perfusion. They have the nomenclature of V and Q. I don't know where Q came from, but probably left over from the cardiologists. And this is your very first introduction to the concept of VQ matching. VQ matching is simply the body's way of matching gas flow in and out of the alveoli, blood flow in and out of the capillaries, and allowing gas exchange to happen in a way that keeps your carbon dioxide levels normal and keeps your oxygen levels normal. By the time somebody hits the age of 70, they will have moved, on average, 220 million liters of air or gas and 220 million liters of blood by the age of 70. It's an enormous feat, and it's ripe for opportunities for screwing it up and causing disease as a consequence. It's a nice segue into just what happens with lung function as the lungs age. This is the very famous Fletcher-Peto curves that show what happens to lung function over the course of an average normal person's lifetime if they are a non-smoker and if they smoke. And what we see is that this is FEV1 on the x-axis, on the y-axis. It's forced expiratory volume 1. It is a very important measure of lung function, and you'll hear about it in one of my lectures tomorrow. But basically, if you look at a healthy person at age 25 and take as 100% their lung function at that age, you see that FEV1 just deteriorates slowly over the course of their lifetime. If they smoke, and if they're susceptible to smoke, not every person is, you see a much steeper downward drop. And the person in their lifetime has the potential to reach a lung function at which they're having symptoms, at which they're disabled. And potentially even in their lifetime, a lung function that's insufficient to sustain life. And the really amazing thing about this curve, and I draw this for patients all the time to convince them to stop smoking, is that if you stop smoking at any point, the slope goes back to what it was if you hadn't smoked. So you have at least the opportunity to make it to the end of your life without disability or without death. Okay, so that's our segue into we've talked about the lungs and health. Again, you'll hear much more about this. Let's talk very briefly about the lungs and disease. I showed you this in the introduction to the course. Basically, all the diseases on the left are diseases of structure and function, diseases of air or gas flow problems, diseases that affect gas exchange, diseases that affect ventilation or perfusion or the matching of ventilation and perfusion. All have the potential to overlap with each other in a variety of diseases. This is just a few slides to show that it's good to be a pulmonologist. This shows the leading causes of death and disability in the world, and you can see that we have some nice ones in the top 10. Chronic obstructive pulmonary disease is the third leading cause of death worldwide. Lung cancer causes more deaths than prostate cancer, colon cancer, breast cancer, and pancreatic cancer combined worldwide. In terms of disability, acute lower respiratory tract infections, you heard a lot about that in your infectious diseases section, are the second leading cause of disability worldwide. Patterns change a little bit for the United States. Lung cancer is the third leading killer. COPD is number 5, and COPD in the United States. Smoking, for the most part, is a disease of rich countries, although that's changing. COPD is the second leading cause of disability in the United States behind ischemic heart disease. You're going to hear about a variety of common diseases in the respiratory system, but I'd like to focus for the next couple slides on common complaints in pulmonary disease. And that's because patients don't come to the doctor saying, I have a problem with my FEV1 or that I have a problem with VQ matching. They come in saying that they have a cough or that they feel short of breath. And if you're going to be a clinician, you're the complaints department. You're the people to whom they come asking for this problem to be fixed. And it's great if you can ascertain that they have a problem with VQ matching. They probably don't care. They want to not feel short of breath anymore. So, these are the common pulmonary complaints that we see most often: shortness of breath or dyspnea. Cough is an extremely common complaint. We also see patients come in complaining of coughing up blood. The lungs actually don't have much in the way of sensory innervation, but the pleura does, the lining of your lungs do. So a lot of pulmonary processes, if they affect the pleura, or a lot of primary pleural processes will cause pleuritic chest pain. Pleuritic chest pain is pain that you have when you take a breath or take a deep breath or when you cough. Patients will complain of chest tightness. That's a very nonspecific symptom, but sometimes patients who have airway resistance problems like asthma won't frankly wheeze, and we'll talk about that in a slide or two, but they'll complain of just a tight feeling in their chest. And then there's a whole host of other complaints related to sleep disturbance or sleep disordered breathing that you'll hear lectured by Dr. Basner about. Okay. The next bunch of slides are basically a review of the approach to essentially any patient, and then I'll talk to you about how we focus that approach from a pulmonary perspective. Obviously, the cornerstone of any clinical interaction with a patient who has a problem, or a patient who's healthy for that matter, is going to be a history and physical examination. From a pulmonary perspective, we have a number of tools that we can do for physiologic evaluation of the patient. We have a number of ways that we can radiographically evaluate a patient, and then we have the option for sampling lung tissue or other elements in the respiratory system for pathologic evaluation. But I want to focus for the next couple slides on just the history and physical examination. Okay. The history, obviously, is the starting point. Context in history taking is everything. Who is this patient is the first question that you have to ask yourself when you're presented with a clinical problem. Obviously, a patient coming in complaining of shortness of breath, your differential diagnosis is going to be completely different if they're a 20-year-old pregnant woman or if they're a 75-year-old man with extensive cardiovascular disease or a 50-year-old woman with morbid obesity. The context of the patient absolutely matters and helps you sort out everything that comes subsequently. In terms of the chief complaint, you do this pretty much in cardiology, you do this in rheumatologic disease. They're complaining of something in particular. Have them describe it. What is it like? What starts it off? What makes it better? How long does it last? In what way does it vary? Does it vary day to day? Does it vary minute to minute? What have they done to make it better? What have they done to make it worse? And then you want to ask about potentially associated symptoms. I'm going to take you through this same little algorithmic approach in a patient coming with a pulmonary complaint in just a few moments. But essentially, this is what we do anytime we take a history and evaluate a patient's chief complaint. Everything that comes subsequently in this algorithm that you've seen many, many times, I believe, you're trying to shed light on the chief complaint. This isn't just for record keeping. You want to know, is there anything in the person's past medical history, past surgical history, or medication history that could explain what the problem is, why they're complaining of what they're complaining. From a pulmonary standpoint, the social history becomes incredibly important, not just smoking, but we'll talk about that in detail, but what the person does, what they do for their hobbies, what their living situation is, how many steps they have in their home, who they live with, what those people are doing in their environment, what their exercise habits are. You'd be surprised at how many people come in at the age of 45 and say, I feel short of breath, but really they haven't exercised a day in 20 years, and what they have is a disconnect between their perception of what they should be able to do and what they can actually do. And they're what we call deconditioned, but not pathologically so. You want to talk to a patient about their travels, where have they been, where did they grow up, and so forth. Smoking, however, is probably the most important element of social history. Important to realize that patients lie. Fairly frequently, I'll examine a patient and they'll smell of cigarette smoke and they'll say that they don't smoke. Obviously, they're exposed to smoke in some way. We talked to patients about the packs per day and the pack years. That's simply the multiplication in the number of years that they are an active smoker or have smoked if they're a former smoker, times the number of packs per day on average. And it gives a very rough quantification to the amount of cigarette exposure. Important, as I mentioned on the Fletcher-Pito curves, not everybody who smokes gets smoking-related lung diseases. There's some susceptibility to lung diseases that goes into patients developing chronic smoking-related lung disease. And you want to record how many years they've been quitting, in large part because of those Fletcher-Pito curves. If somebody has quit 20 years ago and they're complaining of shortness of breath now, it's possible that their past smoking has led to their current disability, but the quit date obviously has an impact. Smoking causes chronic obstructive pulmonary disease in susceptible patients, but it's also a common cause of chronic cough. It is a common contributing factor to a variety of pulmonary malignancies. One sort of interesting side note, adenocarcinoma is the most common form of lung cancer. The single fastest growing group of patients with lung cancer are in patients who've never smoked cigarettes developing adenocarcinoma. It's still a small fraction of the people who overall getting lung cancer, but it just highlights the fact that patients other than smokers get lung cancer. You're going to hear more about lung cancer in your oncology section, which I don't think you guys have had yet. So we're not discussing it in the pulmonary section, but it's one of my areas of expertise, so if anybody has an interest in it, we could talk more about it. Lots of diseases that aren't caused by smoking but are made worse. Be surprised at how many patients with fairly severe asthma, severe enough to put them in the hospital periodically, who still smoke cigarettes. And then there's this long list of everything from periodontal disease to gastrointestinal disease that is made worse in smokers. We ask patients about their exposures. There are a lot of things in the environment, particularly in the workplace environment, that can cause a variety of lung diseases. Asbestos is not too much in the environment now, but causes disease with a lag time somewhere in the neighborhood of 20 to 40 years. So someone's work history 40 years ago could potentially be the cause of their pulmonary disease now. Isocyanates are volatile fumes released in a variety of painting processes, auto body repair, and so forth. Exposure to homelessness increases your chance of developing tuberculosis. Even hot tubs can potentially cause disease, which is a hypersensitivity pneumonitis to a particular mycobacterial pathogen. All right. As I said, everything about the subsequent part of the history is shedding light on the chief complaint. The review of systems is an important element in the pulmonary assessment. You want to see if a patient who probably may not even know that they have occult cardiac disease or rheumatologic disease, if you ask them about their joints, about their skin, you can find evidence of a systemic illness that could be potentially impacting the lungs. All right, moving on to the physical exam. This is the list of, probably add a few more, but a comprehensive physical exam. We're going to focus on just the comprehensive pulmonary elements. We want to look at the upper airway and the neck. We want to look at the position of the trachea and the structures around the trachea that could be compressing the trachea. We want to look at the chest, not just listening to the lungs, but looking at the appearance of the chest. We're going to look at how the chest moves when a patient breathes. There are a variety of things that we can do to assess the chest. Aside from listening, we can percuss on the chest, tapping out, listening for tympany or for dullness. And then we look outside the chest to see signs of pulmonary disease. This is obviously an X-ray, not a photo of a patient, but you can see this patient has what we call the barrel chest of emphysema. Because of trapped air, they have an enlargement over many, many years of the size of their thorax. In just normal day-to-day living, the morphology of their whole thorax has changed so that the AP diameter of their thorax is much larger. You can take a look at a patient, hear their smoking history, see the shape of their chest, and make a diagnosis of emphysema. You can see here, we haven't looked at too many normal chest x-rays yet, but their diaphragms are very, very flat, pushed down by all of this trapped air in their chest. The next couple of slides are a series of cartoons that I drew just showing what normal breathing looks like. It's something we never think about, but normal breathing basically involves the chest expanding and the diaphragm moving down, and the consequence of that is the abdomen moves out when you breathe. If you don't believe this, just have somebody lay down and look at their abdomen move while they take relaxed, normal breath. It moves out in the same way that their chest moves out. This is important to observe because if you screw this up in some way, if you give some element of this system dysfunction, you'll see abnormal movement. So let's give this person, they're very unhappy about it, give them a paralyzed diaphragm. Now their chest moves out, but their diaphragm isn't moving at all, so it gets sucked up into the chest. And the consequence of that is they take a breath in and their abdomen sucks in. And the consequence of that is you see this rocking motion. Their chest goes out as their abdomen comes in. And we call that paradoxical breathing. If you're looking at a patient laying in bed and you see this, you know something is messed up with the respiratory musculature. You can see the same exact pattern in the opposite direction with skeletal muscle weakness. This person has ALS, for example, and their skeletal muscles are not moving much at all, but their diaphragm actually works because it's innervated by some cervical nerves, C3, 4, and 5. Now their diaphragm moves down, their abdomen moves out, and their chest sort of just sucks in because of the draw of the diaphragm. This person has paradoxical breathing. Okay? And then the last scenario where we see this, a person who has obstructed airways, they fall asleep, they get obstructive event from sleep apnea, and no air comes in because their airway closes up. Their abdomen moves down because their diaphragm moves down. No air comes in to expand the thorax, and it ultimately gets sucked in, and you see paradoxical breathing. So paradoxical breathing just tells you that something is wrong in the system. We could spend a whole lecture talking about lung sounds, and you're not going to really understand them until you actually listen to a whole lot of patients. There's some great things online where you can go and listen to audio or video of patients breathing with a variety of breath sounds. You want to listen to the quality of the sounds. You want to listen to the location of the sounds. You want to listen to whether they're inspiratory or expiratory. We talk about two normal types of breath sounds, bronchial breath sounds you hear over the large airways, and then the rest of it, just listening over the lung tissue, you hear what are called vesicular breath sounds. They're relatively quiet. Bronchial breath sounds are like Darth Vader breathing. And that's important to remember because that's actually also a pathologic finding. If you hear bronchial breath sounds at the left base, for example, that's some abnormal air movement. That's not normal and tells you there's some pathology down there. We hear wheezing, which is high-pitched sounds on inspiration or expiration, or both, and then crackles. There's lots of diseases that cause crackles. Crackles are popping open of atelectatic or closed little airways and alveoli, and it gives sort of a crackling, rattling, bubbly sound. We describe them as fine or coarse, wet or dry. There's the specific, in pulmonary fibrosis, Velcro crackles, the sound of Velcro opening up. The nuances here you don't need to worry about. You'll hear all of these over the years. But one thing I would like to point out, so there's two terms, and I'd like to encourage you to use the word crackles instead of this other term, rawls or rails, not just because nobody knows really how it's supposed to be pronounced, but because it was invented as a term by this guy, Hyacinth Laennec, who invented the stethoscope. Just a funny side story. It used to be the common practice of the day to hear breath sounds by putting your ear up against the patient's chest. Laennec had a patient who was very obese, and he thought she had heart failure, and he wanted to know, so he invented the stethoscope. What he found is that he could hear a whole lot of other stuff that you couldn't just hear with your ear. Unfortunately, he called them rails, which is French for rattle, and patients heard this and thought that he was talking about the death rattle that people make when they're in their last gasp of breath. So he stopped using the word rails, and so should you. Okay. So just some extrathoracic manifestations in patients who are very hypoxemic. Deoxygenated hemoglobin is purple. You can see it in the fingertips. That's digital cyanosis. Clubbing in this instance is not the rave kind, but the digital kind, essentially in a variety of pulmonary diseases. And nobody really understands completely why. It has nothing to do specifically with hypoxemia, but certain diseases cause evil humors in the body or vascular problems, and you get this disruption of the normal angle of the nail bed. They look like little, when it's really severe, like little drumstick heads. And they're also called Hippocratic fingers because Hippocrates first described them. But in any case, if you see them, something's wrong. This is a disease manifestation of lung cancer. It's quite uncommon, but you never ever see it in a patient with just COPD. So if you're taking care of a patient with COPD and you examine them and you see clubbing, you're going to say, hey, something's going on here and we need to investigate, and you'll find that they have lung cancer. All right, we have a variety of tools. I'm not going to go into detail in any of these because you hear all about them in subsequent lectures, but the arterial blood gas analysis is one of the most important. It gives us the fundamental building blocks for evaluating gas exchange, our PCO2, or our arterial carbon dioxide level, and our PaO2. And again, no detail here because you're going to hear about them tomorrow. We have a variety of imaging techniques. The most commonly used in pulmonary medicine are just plain chest X-ray and CAT scanning, although we use ultrasound to look at the pleura. We use MRI infrequently in the lungs to look at the chest wall or the pulmonary vasculature. We use echo to assess the pulmonary, the right side of the heart and the pulmonary vasculature. We can use VQ scanning, PET scanning, angiography infrequently. But fundamentally, chest X-ray and CAT scan are our most important tools. This is a normal patient. I'm not going to teach you how to read a chest X-ray in one 50-minute talk. You're going to look at hundreds of these over your clinical years, even if you're going into dermatology, and you'll learn what normal looks like and what abnormal looks like. Over the course of the next 2 weeks, I encourage you to go back to this slide. When somebody shows what a chest X-ray looks like in pulmonary fibrosis, go back and look at what normal looks like, and you'll start to learn exactly what the differences are. Sometimes, particularly in chest X-ray, the differences can be quite subtle. We use the lateral view to look at, obviously, a different perspective, but also to look at the sulci areas behind the heart. Remember back to the anatomy that we talked about and just look where the position of the various lobes are. On the right side, the right upper lobe sits mostly in the right upper lobe of the chest. The right middle lobe sits medially and anterior to the right lower lobe. And the right lower lobe actually has, as in the superior segment, a tuck of lung tissue that goes up fairly high in the chest. On the left side, same deal. Those are the fissures. On the left side, sort of the same arrangement minus the middle lobe. The heart takes up some space, but the lower lobe goes very low down onto the chest X-ray. So you can have a lower lobe tumor that sits fairly low in the chest. You can have a lower chest tumor that actually is in the upper lobe if it's anteriorly. This is a patient who actually has a pure right upper lobe pneumonia. Now, their right upper lobe actually tucks a little bit lower than the average person's does, but this person doesn't have anything at all in their lower lobe, and you can see it looks like the lower portion of the chest would be affected. It's actually not. It's all upper lobe disease. I put in this particular CAT scan because it shows three different types of lung findings on a CAT scan. You see much finer detail and the sponginess of the lungs, which is basically what you're seeing is not the lung tissue itself, but the pulmonary vessels. This is an area of normal lung. If I can get my browser back, an area of normal lung here. This is an area of underperfused lung. You can see it's just a little bit darker. And then this patient has fairly extensive areas of what we call ground glass abnormality. It looks like somebody just sprinkled ground up glass on the CAT scan to give a faint hazy picture of a wide variety of diseases, mostly inflammatory conditions or things that affect the alveoli. Filling them with fluid can cause ground glass. Okay. So just changing gears for a moment, we're going to talk specifically about how we use what we just learned a couple minutes ago in terms of the history and physical for a pulmonary patient, what we learned in terms of some of the diagnostic tests for a pulmonary patient, how we evaluate two common pulmonary complaints. And I don't want you to think that you need to come away from these next two subsections of this particular talk understanding completely how you would take care of a patient with acute dyspnea. What I want you to focus on is just sort of the structure of the algorithm, how we use what we learn in the first part, the history and physical, to structure a differential diagnosis and then apply some of those tools to sort out what's going on and to help manage a patient's problem. So I'm going to start just with probably the most common pulmonary complaint. Now, this picture obviously looks fake, and I know it's fake because patients don't ever turn their head and they don't ever cover their mouth when they come to see you. They think that pulmonologists are immune to all pulmonary diseases and that you have to feel their warm breath of their cough in order to just know how deeply bothered by them they are. So they will cough right on you. So we're going to apply that same history taking in terms of assessing the chief complaint that we talked about a couple slides ago to the cough. What is the nature of the complaint? What causes it to come out? What scenarios does it come out in? What's the variability? Is the cough wet or dry? Is it constant and all day long, or does it occur just in the mornings? What makes it better? What makes it worse? Most important, however, is going to be the duration of the cough. These other things here are going to be helping you sort out in terms of the chief complaint. Patients may not mention that they're also short of breath. You have to tease out some of the elements of what is wrapping around the chief complaint to help you figure out what's the appropriate differential diagnosis. But duration of the cough is actually quite important because it's going to help us do some main broad categorizing of the causes of cough. It's a relatively evidence-based differentiation. We tend to group cough that's been lasting less than 3 weeks as acute cough, and everything longer than that as subacute or chronic cough. Obviously, context can affect our assessment of this to a great degree. This is a little bit out of order, but you want to ask about sputum. I forgot to mention that in assessing the chief complaint. When patients have a cough, it's sometimes, and when you've all had coughs, it's sometimes wet, it's sometimes dry. Asking them what they're coughing up can help you tease out whether this is an infectious cough, whether this is a non-infectious cough. Even some specific bacterial pathogens cause a particular change in the sputum in a particular color. You want to ask them to quantify it. Usually I have patients talk about teaspoon per day or cups per day. Patients with bronchiectasis or chronic bronchitis can make a cup of mucus a day, and you want to help them quantify it to determine whether something's changed or whether something's new. Common causes of acute cough. We've all had acute cough. Viral upper respiratory tract infections make up the vast majority of those. Acute bacterial sinusitis is a cause for cough. A variety of other infections, including pertussis. Exacerbations of chronic obstructive pulmonary diseases can lead to an acute cough, and pneumonia can present as acute cough. You can have a fairly significant multilobar pneumonia, and if you're young and healthy, you might not be short of breath or have pleuritic chest pain, but you may be coughing up sputum. You want to basically ask yourself as you go through your history and physical, these are the common causes, these are relatively easily treatable causes for the most part. Is there anything in the history and physical that makes me think that there's something more going on? Is there something more that I should be worried about? Does the patient have cachexia or clubbing on their physical examination? Does the patient have HIV or signs that they might have HIV to suggest that they have a compromised immune system? And then in their history, their occupational history, have they been exposed to something that could potentially take them off this list of common things? Subacute cough is a very different animal. The vast majority of people who have a cough that's been lasting for more than a month are going to have either upper airway cough syndrome, which is this plain old postnasal drip, something irritating their upper airway and causing it to drip down below, or a variant of asthma. There's a cough variant of asthma where patients don't wheeze and don't complain of shortness of breath, but just cough, or gastroesophageal reflux. Now, 3 very different reasons, but all 3 of them very, very common, and together they make up 90% of the reasons why somebody could be coughing for 3 weeks or more. Again, in the same as the assessment of acute cough, you want to ask yourself, is there something in this patient's history or this patient's physical examination that makes me worried that I'm not dealing with one of those 3? And that's your starting point, your history and physical examination. And if the patient has, after you've talked to them, no clear rationale, no clear thread that makes you think that potentially they have an undiagnosed asthma, or potentially they have undiagnosed reflux, or potentially they have upper airway cough syndrome, you may want to do a chest x-ray. These are not hard and fast steps. Obviously, you're going to adjust these based on the clinical circumstances, but a plain chest x-ray gives you a very nice starting point. So we have no idea what's causing this person to cough. They've been coughing for a month. You may want to do a chest x-ray even if it's, you have a general thought that maybe they have reflux anyway if the cough's been lasting for months and months and months. But a normal chest x-ray takes a lot of serious things off the table, at least temporarily. And if you've taken things off the table and you have, with a normal chest x-ray, and you have no idea whatsoever what this person has, and you think that they don't have something serious, you take an empiric treatment approach. You potentially treat them for 1 or more of these things and see if the cough goes away. And in a large percentage of patients, things will go away. If it doesn't, that's when you bring in your other diagnostic tools and consider doing a CAT scan, or consider doing an invasive evaluation for reflux, or consider doing something else to determine why this person's coughing. And that, I think I had somewhere in here, there's a reference. Yeah, there's a great New England Journal article. If you want to, you can go back and take a look at the full spectrum of acute and subacute and chronic cough and how you manage it and how you treat it. It's a great article. Okay. So the other common pulmonary complaint that I'm going to finish with is dyspnea. You're going to hear about dyspnea over and over and over again over the subsequent slides. Again, this is not meant to be comprehensive. This is how I manage a patient who's short of breath. I just want you to look at the structure and the framework and how the physical exam and how the history taking sort of helps you hone your differential diagnosis. Dyspnea is just simply at its most basic, I alluded to this earlier, a subjective sensation or a subjective experience on the part of the patient of some form of breathing discomfort. It could be that they're feeling tight when they breathe. It could be that they're winded when they try and walk stairs. It has a variety of manifestations, but it's the patient's general sense that their breathing isn't what it should be. It is not what it should be. Dyspnea can be acute or chronic. We worry much more about sudden, severe onset of acute dyspnea than chronic dyspnea, as we'll talk about. It can be with exertion or with rest. We're going to start with just 2 cases and highlight how they're different. So this is a 55-year-old man. We're not going to give you any other history. He's coming into the emergency room saying he had acute onset dyspnea 1 hour ago. What is your general approach to this patient? So you have to ask yourself, is there potentially something quite serious going on? And the answer is absolutely. Is it possible that there's nothing serious going on and this person's very anxious for some reason? Absolutely. But there's the possibility that you need to make some intervention. This is this has emerged very rapidly and therefore is a potentially emergent problem. So this is basically what I've sorted out as 5 individual steps in approaching this patient. But in real life, you're going to do a lot of these things simultaneously and gather information in increments based on the speed with which you need it. So we're going to start with the ABCs. You guys have all learned about the ABCs, airway, breathing, circulation. Is this patient either dead or almost dead? And do I need to intervene in that regard? And once you've gotten that off the table, you have just a little bit more time. Maybe not a lot more time, because a person with acute onset shortness of breath could be heading towards respiratory failure. The system may be stressed to a point where it's about to fail and no longer meet the needs of the body in terms of getting oxygen in and carbon dioxide out, or both. We want to do our history and physical. Obviously, ABCs are the start of that. And essentially, we're assessing for causes of dyspnea, this person's 1 hour of shortness of breath, and building a differential diagnosis as we do it. We then can use that information to apply diagnostic testing and then management strategies. So impending respiratory failure, you get a whole lecture on this. But some of it are just basic and in the vital signs. Is this person breathing at 40 breaths a minute? Is this person heart rate 160 or 120? Is this person confused, potentially as a consequence of carbon dioxide levels being high? Is their work of breathing high? Are they using accessory muscles of respiration? Are they working hard to breathe and paradoxing because of some problem with the system? Breathing fatigue, I've worked for the last hour and now I'm too tired to keep going, is something that you will learn how to recognize. It can be a very paradoxically calming scenario. A person breathing at 40 is suddenly breathing at 20 and then suddenly breathing at 10. And that could be great if you've given them a medicine and you've made them better, but it could also be a sign that they're actually heading toward breathing of 0 and death. So you have to pay attention. Nasal flaring I didn't talk about, but somebody breathing so hard that they're actually flaring their nostrils open to get more air into their body. It's a sign of impending respiratory failure. Okay. I'm not going to go into detail about the arterial blood gases. You're going to hear about these starting tomorrow. And just as I said, trajectory can be critical. And that can be in the physical exam, that can be in the vital signs, that can be in the blood gases. Impending respiratory failure, you're going to learn to recognize. Okay. And the reason, you don't have to memorize this slide, but you have to understand that dyspnea has a variety of causes. It can be cardiac in origin, it can be pulmonary in origin, it can be metabolic in origin, and you have these categories. Starting with those categories when you're approaching a patient is a very important way of organizing your thoughts, and it helps you organize your physical exam and helps you organize your diagnostic testing. I'm going to elaborate on the next slide on the sort of fleshing out those variety of categories. Again, you don't need to memorize the slide. Just eventually, as you move through your clinical years, you'll learn about all of these things. Keep these categories and keep these buckets of potential problems in the front of your mind, and as you sort out for an individual patient, you'll be able to narrow your differential diagnosis into hopefully a smaller list than this. History's critical. Context is everything, as I said, and your examination, particularly in the setting of an acute episode, is going to need to be focused. Okay, these are the variety of diagnostic tests that we might employ. You'll hear about more of these the rest of the lecture. I'm also going to not talk in too much detail about managing acute dyspnea, but we may want to fix this person's problem. If they have a ventilation problem, we probably want to fix this person's problem. If they have an oxygenation problem, and we probably want to pay close attention to this person for their trajectory. And because we're running out of time, I'm going to just introduce this slide. It's basically just a list of some of the things that can cause acute onset dyspnea and a list of some of the interventions that would be appropriate for that particular patient. Sort of finishing up with chronic dyspnea. This is a patient who comes in, a 67-year-old woman. Again, we're not getting any more history, but she's coming in with 6 months of dyspnea. Obviously, something's not as acute by definition. Something's not as emergent. Something caused her to come to the doctor now and not 5 months ago. So it doesn't mean that just because she's been short of breath for 6 months that she's not an impending respiratory failure, but probably not. This is sort of a problem that's played out over a longer time. We're going to approach this patient pretty much in exactly the same way. We're going to assess their ABCs, we're going to do a history and physical, we're going to apply our diagnostic testing, and we're going to do some form of intervention. Again, we want to ask the patient about all of the things that affect their dyspnea. Particularly, you want to quantify dyspnea. Yes, you're short of breath. Are you short of breath when you walk up 1 flight of stairs, half a flight of stairs? How is that different from a month ago? Sometimes people will describe, or you can ask people to describe how many blocks can you walk. Make it very concrete. Can you walk to the store, the store that's 2 blocks away? Can you walk to the store that's 3 blocks away? And you can get a sense and trajectory over time of how this person's shortness of breath has played out, and you can glean hints as to the etiology based on that. This is a list of all of the things, again, broad categories of things that can cause a person to be chronically short of breath, including deconditioning, including things that have very little to do with the respiratory system structurally, like anemia or hyperthyroidism. However, as is the case with chronic cough, chronic dyspnea has some very, very common actors. About 2/3 of patients who come in saying they're chronically short of breath will have either some obstructive airways problem, either asthma or COPD, or some what we call interstitial lung disease, some problem with the lung tissue, and you'll get a series of lectures on those, or a heart-related problem, a left heart problem causing their shortness of breath. I'm going to skip over this. Basically, this is just a fleshing out of the various pulmonary causes that can result in a patient being short of breath, including pulmonary vascular causes, pulmonary hypertension, including problems with the chest wall itself, including problems that have nothing to do with the lungs. You can have absolutely perfectly normal lungs, but if your respiratory muscles are weak with a neurological disease or neuromuscular disease, you will be short of breath and have manifestations of respiratory failure, or potentially. You want to use your history and physical to apply appropriately your diagnostic tools. You don't want to get all of these on every patient. A person coming in with 6 months of shortness of breath, an EKG, a chest X-ray, and some labs might be appropriate, regardless of what else you've gotten from the history and physical. But you want to be judicious in using your spirometry, which you'll hear about, pulmonary function testing, and things like CAT scans, which cost a little bit more money. And then you can treat their chronic dyspnea. Again, you'll hear about this in subsequent lectures. So I'm going to end with this patient's slide and just ask you to think about why this person might be short of breath. Now, this person, I didn't tell you anything about this, but this is a 70-year-old woman who, I'm sorry, 70-year-old man who has smoked 150 pack years. They have smoked since they were age 20, 3 packs a day. And now they have horrible destruction of their lung tissue from emphysema. They have very little lung tissue left. You can't see this very well in this projection, but they have very lucent lungs. And they have hyperinflated lungs. They're very big in the anterior, posterior dimension. Their diaphragms are very, very flat. Why is this person short of breath? And the answer is, who knows? Are they short of breath because their oxygen levels are terrible because they have destroyed lungs? Are they short of breath because they're ventilating poorly? Are they short of breath because mechanically the diaphragms just have no room to move? Are they short of breath because they haven't been able to walk more than 20 feet for the last year and they're horribly deconditioned? Are they short of breath for a host of other reasons? And the answer is they're probably short of breath for all of those reasons. This is a slide listing just some of the physiologic pathways that lead to dyspnea, but patients are very complicated, and there's very rarely one specific problem leading to why somebody's dyspneic, and I just sort of throw that in there to make you understand that shortness of breath is a very complex process and can be affected by many, many different things. So. My apologies if that was sort of a whirlwind introduction. As I said at the very beginning, you're going to hear about all of these elements again in a variety of different venues. The first couple of days over the next 2-3 days are going to be all about pulmonary physiology in the normal and in the abnormal situation, and a lot of histology, learning about just the structure of the lungs. I hope you guys have a lot of fun. This is meant to be a low-stress section. But if you have, at any point, difficulty understanding some of the conceptual elements of it, please get in touch with Amy and I, and I wish you good luck for the whole section. So we're going to have a 10-minute break now, and then we're going to have Alan Borshuk here. 5-minute break, sorry. I apologize for going a little bit over. We're going to try and keep all of our lectures to 50 minutes if we can. But come back in 5 minutes. We'll introduce you to Alan Borshuk. Okay, 10 minutes. So we'll start at 5 after the hour, and we'll take an extra long introduction. Now, this is theirs for videotaping. So are you still on?
Hi, thanks for a great lecture. Quick question. So it's probably indicative of pretty late stage. Like, for lung cancer, you have to have a lot of something's going on. So that's actually
Your first, you have 2 events, right? I hate my emphasizing that. I don't know that there's a good way to make foundation exciting. I actually spent in physiology 4 imagining way more time thinking about how to introduce it than actually. And I ended up just doing introducing it as a little bit of it occurs normally, and that was applied in physiology. Yeah, it's magic. You wanna? Where's our tech right here? Because we don't have it up on the screen.
No? Oh, maybe that's how to do it. Oh, okay.
All right.
That was easy enough.
So we're gonna get started again. I want to have everybody take a seat if you could. We're going to move on to embryology and histology of the respiratory system. And I wanted to introduce Dr. Alan Borshuk, who is in the Department of Pathology here, is Columbia's expert on lung pathology, and we're very, very fortunate to have him speaking to you in this lecture and then a series of subsequent lectures. Thank you, Alan.
So, in the first lecture of your course, you learned a lot about disease and terminologies which will come up again. But in many ways, the miracle is that all of it works normally most of the time and develops that way normally most of the time. And it is quite amazing. We sort of ignore it in a way because we're so focused on the disease manifestations, but it really starts with understanding what's normally present in lung, and to some degree understanding the embryology of lung development. And probably the purpose of understanding development is that there are some diseases and some malformations that are related to abnormalities in development. So there are some things that we teach purposefully to give you an image of what things look like so that you don't have an imaginary view of what something may look like. And then other things we really teach directly towards the fact that an abnormality in that area causes disease. And the more questions you ask, the more you realize that there are unknown areas in all of these things. And as I said, it's because it is quite the miracle that lungs form the way they do almost the same way every time in millions and millions and millions of people. And that the diseases are, in fact, largely the result of injuries to those tissues. But the fact that they form is quite remarkable. And so with that in mind, we're going to start off with actually histology. That is, what are the cell populations in the lung, and in a way, what needs to be made. Then we're going to talk about the embryology and go back and show how those things do get made during development, at least from an overview. And that'll lead into discussions of branching morphogenesis as well as developmental abnormalities and immature lungs of immaturity. Normal lungs are actually quite hard to come by to show you a normal lung in an adult because so many people are exposed to environmental things, cigarette smoke, dusts in general in the environment, that very quickly the lung parenchyma, as you get into your teens, 20s, 30s, 40s, have an increasing amount of black pigment in them. And so to show lungs that are relatively normal is hard to do. These are relatively normal. This was a young person, non-smoker. And you can see the cut surface of the lung is really pink, tan. These occasional black spots are an indication that no one can seem to escape some dust exposure. And so that is, in fact, carbon particles from the environment. Areas will have more blood in them, and they will look more red. But the fact is the cut surface of the normal lung should be tan pink, not brown, for example, not bright red, diffusely. Again, blood will make it red. And when we look at the pleural surface, it should look actually fairly transparent and almost inapparent. And when we look at the parenchyma itself, while we know that there are alveolar sacs there, looking at it at this view, which is about at arm's length, you really don't see them in normal lungs. If you bring the specimen very close, you will be able to then resolve alveolar sacs. Okay, just to give you an idea of size and normalcy. Okay. So now we're going to move into the histology of the lung. And I always go through the airways first, because that's the main focus. The airways are really the main function of the lung. And in that, there's part of the airway which I'm going to call the conducting part of the airway. That is, the parts of the lung which bring air into the lung, but for where gas exchange does not occur. And then the respiratory portions of the lung, where gas exchange does occur. And we're going to separate those. And since part of the function is to get oxygen into the bloodstream and carbon dioxide out of the bloodstream, there has to be a blood supply to the lung, both to maintain lung viability, but also for purposes of gas exchange. And we're going to talk about that as well. And lastly, the envelopment of the lung, which is called the pleura. So when we talk about the airways, we have to divide them up into different sections. And we start at the trachea, and the trachea then divides into two bronchi. And the entire process essentially is a series of branch divisions, which can be somewhere in the vicinity of 20 to 23 branch generations, ultimately leading to the alveolar sac. And this is what's attempted to be demonstrated here. Bronchi are cartilage bearing. The bronchi divide, then they eventually lose their cartilage and become bronchioles, which then divide to the terminal bronchiole, the end of the conducting part of the airway. And then as branching continues, one ends in these alveolar sacs. And from respiratory bronchiole to alveolar sac is the gas exchange or respiratory part of the airway. These branches occur in a fairly consistent way. The segmental bronchi have 10 on the right and 9 on the left. Branching continues, and as I said, you'll see that the histology of the airways changes as that branching continues. So if we focus on the conducting zone, there's first the trachea, then bronchi, and then bronchioles. And the cell types that are lining them are ciliated cells, goblet cells, which make mucus, basal cells, which are the reserve cell of the airway. When there's injury, these are the cells that divide and then differentiate to the other cells. And then Kilchitsky cells, which are neuroendocrine cells in the airway. So the trachea is where we start. The trachea has an anatomy, which you've seen in anatomy. It has a C-shaped cartilage and elastic tissue. Its epithelium is pseudostratified epithelium. We'll talk about that in a moment. There are goblet cells. There are submucosal glands, reserve cells. And these are all the words we're going to go through in the next slide, lamina propria and submucosa. So when we look at that section of trachea, and you'll see that we're going to say almost the same thing for bronchus, there's epithelium, and then there's some connective tissue with vessels and some inflammatory cells beneath it. The epithelium plus that tissue underneath the epithelium together, the epithelium being the cells lining the surface, the vascular and connective tissue being called lamina propria. The combination of epithelium and lamina propria we refer to as the mucosa. Now, in the gastrointestinal tract, there are more distinct separations between mucosa and submucosa. There's a more defined muscle layer that divides that, not so much in the airway. Yet, we figure that by the time we get to this layer below where the glands are here, that this must be below the mucosa, and we call these submucosal glands. And so again, you've got these glandular structures that have to find a duct to the surface, this being the lumen. You have epithelial lining. You have glands that make a variety of secretions, watery and mucoid. And this is really the mucosa. And again, as I mentioned, the demarcation in the respiratory tract is not as clear as it is in the GI tract between mucosa and submucosa, but nevertheless, one starts to have those glands and it becomes relatively apparent. These are the seromucinous glands. The ones that are slightly pink are the serous glands. The ones with the vacuole are mucinous glands. And so secretion in the large airways is really important. The mucus that is produced by the large airways, both by these cells and also by the goblet cells that I'll show you in a moment, are really critical to maintaining this kind of mucociliary elevator, which is really critical to trapping particles and keeping the air passages clear of damaging particles. And so there's mucus, there's seromucinous secretion. This traps particles. The cilia beat in rhythm and bring all that mucus up and out of the airway and traps those particles, which include bacteria. So then we need that ciliary elevator. And so the epithelium is a pseudostratified ciliated epithelium. Here is the epithelium. It looks stratified, but in fact, all the cells have an attachment on this basement membrane below. These are the reserve cells, and these cells here have cilia at the end, and these are the ciliated cells. In some regions, you can see the goblet cells, which again contain mucin. So mucin is derived by the seromucinous glands as well as the goblet cells. The goblet cell and the ciliated cell reach the lumen. The reserve cell is attached to the basement membrane, but is not a cell that reaches the lumen. And so all of this is together, and I use this picture because this is really a scanning electron microscopy image, and it shows you that when you look at the surface of the airway, you're seeing essentially all the ciliated cells, an occasional goblet cell, and sure, there's a white blood cell and a red blood cell here as well, but what you're seeing is essentially a lawn of ciliated cells. And these cilia beat rhythmically, and this is what enables you to clear secretions from your airways. Clearing secretions from your airways is critical, again, to reduce particle load that reaches the lung, and also to prevent bacteria from reaching the lung, which will also get entrapped in that mucus. Now, this is an ultrastructural appearance of cilia, and cilia have a very distinct architecture. These are microtubules. There are 9 microtubule pairs around a central doublet, and there are these little proteins that are called dynein that allow for the movement of the cilia. I show you this because, again, to start introducing disease correlates, one can have a mutation in that protein that eliminates the dynein, and without dynein, the cilia don't beat. If the cilia don't beat, mucus accumulates. If mucus accumulates, it traps particles and infectious organisms, but you don't clear them. Eventually, a pathogenic organism will get in, and you'll have repeated pneumonias, repeated infection. Repeated infection will damage the lung, and we'll talk about that in the path overview lecture as bronchiectasis. Getting back to the airway, we stopped over here, but there are other elements. This is the cartilage that's in the trachea and the bronchus, which gives it structure and prevents it from collapsing. Of course, for the trachea, at least some of it is protective anteriorly from trauma. There are nerves and there's adipose tissue, all of which are the connective tissue components of the airway. If we move from the trachea to the bronchus, we find very similar cellular populations. There's the cartilage that defines it as a bronchus relative to a bronchiole. Here is, again, the pseudostratified ciliated epithelium with some goblet cells. As you go more and more distal into the airway, there are fewer and fewer goblet cells. The secretion becomes different as one moves into the distal airway. Here's the basement membrane, the lamina propria, smooth muscle, which is responsible for airway tone, which you'll learn about in your lectures on asthma. And if we again look at the epithelium, it is ciliated, and there's a basal layer of reserve cells. Okay. So the function of airway epithelium, and so I've already alluded to this. I know this might be a little repetitive, but nevertheless, it really drives home the normal structures. Part of the function of epithelium is barrier. And when we say barrier, there's a barrier to a lot of things. For example, your nasal passages, part of their function is the same, to trap particles. Part of it is to warm the air, to make sure that cold air is not reaching this very delicate gas exchange membrane. And realize that's the delicate part of the lung. The airway influences the smooth muscle tone, and so the epithelium influences smooth muscle tone both directly and indirectly. The function of the epithelium is the ciliary elevator, to trap particles and to move them out. The mucus secretion comes from the seromucinous glands and the goblet cells. Importantly, it contains IgA, it contains complement. It has important proteins in there, including antioxidant proteins. And the epithelium is functionally capable of allowing for the calling in of inflammatory cells when it's injured. The neuroendocrine cells are less clearly, have less clear function. They do seem to be involved in smooth muscle tone. They do have a function in sensing oxygen. They do have the ability to cause other cells to divide by their secretions. And during development, the neuroendocrine cells do seem to accumulate at the branch points, which we will talk about during the development part of the lecture. So, moving on from the large airway, which again is the conducting airway, which is cartilage bearing, to the bronchiole. Generally, the bronchiole is the division where the luminal size is roughly 1 millimeter, so you're getting into structures that are just visible to the naked eye and just into structures that are becoming microscopic, and these don't have cartilage. Again, the cartilage being more of a protective function in the larger airways. However, the total cross-sectional area of the bronchioles is actually greater than the bronchi. And that's a really important point, because if you contract muscle in the bronchioles, you are really narrowing the largest cross-sectional area in the lung. And therefore, this is really where muscle tone determines airway resistance. There are few to no goblet cells in the bronchiole, although when injured, that you can get metaplastic goblet cells, but normally they're not goblet cells in this part of the airway. Again, the secretion becomes more watery than mucinous. And again, the proximal part of the bronchiole has the ciliated cells, the reserve cells, not too many goblet cells, scattered neuroendocrine cells, and I missed it right here, but we'll talk about that in a moment, increasing numbers of Clara cells terminally. And so here's an attempt to show you in what is a picture of a three-dimensional cast this transition from a conducting airway to something that branches into more conducting airways and eventually becomes the thin-walled respiratory bronchiole, alveolar duct, and alveolar sac. All of this happens in a relatively short distance. These structures are not very long, in fact. And here's the histologic correlate of it. We have an airway. Here's the epithelium. There's this smooth muscle. This is the bronchiole. Again, no cartilage, no seromucinous glands, no goblet cells. And in the course of one histologic section, I can show you the terminal bronchiole, which is the end of the conducting bronchiole, transitioning into the respiratory bronchiole. And you can see now the distance between the epithelium and the air sacs is becoming thinner and thinner. There are fewer and fewer cells in between, into the alveolar duct and in the alveolar sac. So this is the transition from the conducting part of the airway to the respiratory part of the airway. And so here, ciliated cells still, no goblet cells. There is muscle still, no seromucinous glands. If we look at the midpoint, we have a new cell population. This cell that we're going to call cuboidal. It's called cuboidal largely because its length and width and height are about the same. And so these aren't tall, thin cells. These aren't big, flat cells, and we call them cuboidal. These are the club cells, which I mentioned briefly in the other slide. Now, I did this intentionally. These cells were called Clara cells, and I missed it on that earlier slide to get rid of it, but they've been renamed club cells. And you'll see that an increasing number of medical terms are being renamed because they were named after certain folks who may have made discoveries, but the discoveries were perhaps made in ways that are unethical or immoral. And so Clara has been removed from the name of this cell, and it's now called a club cell. And so club cells are the population of the end of the terminal bronchiole to the respiratory bronchiole. The terminal bronchiole still has ciliated cells, but as we make that transition, just like I did across the slide, there are an increasing number of these club cells until one gets to the respiratory bronchiole, and all of the cells will pretty much be club cells. The club cells produce a component of surfactant, which is critical in keeping the airways open during inspiration and expiration, and are also the reserve cell of the bronchiole. And so again, when there's injury to the bronchiole, the club cells divide. So their function, while a population of cells that seems to be confined to this one transition segment of the airway, the club cells are fairly important. They are important for chemical detoxification. They also have an antioxidant effect in their secretion, CCSP, which is now club cell-specific protein. So the C was maintained so that not all the names would have to be changed. Surfactant protein B is also a secretion of the club cell. There are inhibitors of inflammation, as well as proponents or factors that increase inflammation as needed. And also there's an inhibitor of neutrophil proteases in this part of the airway, which you'll see is important in the setting of emphysema, which we'll talk about in the next lecture. These are, again, also the progenitor cells, both for the ciliated cells that are in the bronchiolar region and other club cells. And so the cells in this segment of airway we can highlight with an immunohistochemistry, essentially a reaction that we can do in tissue which causes cells that contain a particular protein to turn brown. And thyroid transcription factor 1, despite its name, is really critical for lung development. But in adult lungs is important for the regulation of surfactant protein secretion. So cells that make surfactant proteins express TTF1. And so here, for example, we can now see how many of the cells are really club cells in that segment of airway, same segment that I showed you before, except it sort of flipped around the other way. And so you can see that here there's an intermingling of cells, but then eventually they all become club cells, and then here's the transition into the alveolar duct. So again, now on H&E section, the club cell, and now the club cell as it transitions from that respiratory bronchiole into the alveolar duct, and eventually the last branches, which are the terminal sacs. You can see that the club cells, which are almost all in a row, are then replaced by the population that line the alveolar duct and the alveolar sac. So this is truly the transition to the gas exchange part of the lung. And so when we talk about that part of the lung in the alveolar ducts and sacs, we're talking about two cell types. And they've been conveniently not named after anybody, so we don't have to rename them. They're type 1 and they're type 2. Type 1 cells are, again, the morphology of a type 1 cell is a big flat cell. To be a lining cell, to remain a barrier, but to be as thin as possible to facilitate diffusion across the membrane, because that's the cell through which diffusion occurs of respiratory gases. The type 2 cell is a more cuboidal appearing cell, and it's responsible for surfactant production components, as well as it is also the reserve cell in the alveolus. So the type 1 cell is a thin, flat cell, and right up against it is an endothelial cell that lines the alveolar capillary, and I'll show you that in the images. So again, to maximize the surface area for gas exchange and to minimize the distance needed for those gases to cross, so that in the course of a breath, not only can all the gases that need to be exchanged reach equilibrium, but they do so actually even in only the first portion of the respiratory exchange. In other words, you don't even need the entire breath to get all the gases across. That's how efficient it is. And you'll see that in your physiology lectures. And you'll see what happens if you introduce any space, whether by inflammation or by fibrosis. And you can imagine the more cells in that space, the harder it is to get diffusion across that membrane. Once you get to 4 or 5 cells thick, you no longer can depend on diffusion to get materials across a membrane. Okay? So it's really critical, this structure. It's also very delicate. This covers 90% of the alveolar surface. This is a terminally differentiated cell. It itself does not undergo mitotic division. It is a thin cell, as I said, that allows the gas exchange by diffusion. The type 2 cell produces surfactant proteins and lipid. It is the cell that does divide and will regenerate, and the hyperplasia of these cells is seen when there's injury to the alveolar membrane. It's important for sodium transport. It also recycles surfactants, so type 2 cells are a green cell. It's a source of a variety of factors that are important for vasoconstriction as well as for cell growth in that part of the airway. Okay, so we've described them. Now we have to look at them a bit. This is the alveolar sac. This is where air would be. Here are the alveolar walls, and it's even hard to recognize a nucleus of either endothelial cell or epithelial cell, because these cells just have so much more cytoplasm than they have nucleus. They're big, flat cells. And so occasionally you'll see a flat cell that's probably the nucleus of an endothelial cell and of an epithelial cell. And then this little cell that's sort of bulging into the lumen, that's a type 2 cell. Here, an even thinner type of section that's used for EM, where you can see this little cell that's sort of bulging into the lumen is a type 2 cell. This is the alveolar capillary. That's the endothelial cell. And again, there's both an endothelial cell and an epithelial cell cytoplasm between the lumen of that space, here the capillary space, and the air space. So you can see just how thin that membrane truly is, barely even 1 cell thick in its normal structure. Okay? So again, capillary, type 1 pneumocyte, type 2 pneumocyte. Again, in scanning EM, you can see their shape in a different way. You can now imagine that this picture is a section through the alveolar wall this way, and so the type 2 cell sort of bulges just a little bit. So you see that you have essentially a space. I'll do it. Okay, a space which is smooth lined, which are really all the type 1 cells, and these occasional cells that are bulging in. Again, 10% of the surface area, but nevertheless present. And this is essentially the inside of an alveolar space, all at 5 microns is that bar right here. So you can see just how small these structures are. This is a normal TTF1 immunohistochemistry on normal lung. You can see the type 2 cells, again, surfactant-producing cells. They express TTF1. TTF1 is a regulatory transcription factor that controls surfactant production. And here with lung injury, now the alveolar wall is thickened. These are not all type 1 cells. In fact, these are all type 2 cells. When we see a proliferation of cells, we'll call that hyperplasia. This is type 2 hyperplasia, because it's a hyperplasia of type 2 cells. Okay? And so again, now if the alveolar capillary is in the middle here, and this is the airspace, you're no longer crossing this very, very thin membrane. You now have to get from here all the way to here to get gas exchange. And you could imagine that this does result in problems with oxygenation. And you'll see this in your lecture on diffuse alveolar damage and the adult respiratory distress syndrome. Now, I've taken you all the way through from the conducting airway to the respiratory zone, to the cells that change from cells that are generally involved in barrier, mucus production, mucociliary elevator, to cells that are really focused on keeping the airspace open, which is the production of surfactant, because this reduces the surface tension in the alveolar space, and secretions that are antioxidant, secretions that are antibacterial, and so the cells have changed function to cells that are really designed to allow the structure for gas exchange to be as efficient as possible in the course of a breath. All right? Now, we got all the air in, but we need to get the particles of, well, we need to get the gas into the bloodstream, and we need to get the gas out of the bloodstream, and so there has to be a blood supply. And so in the lungs, you will see different types of vessels. There are arteries. The arteries typically travel along with the bronchi and bronchioles, so we refer to it as the bronchovascular bundle. These are the arteries that come from the pulmonary artery. The vessels from the pulmonary artery produce a capillary bed that is, in fact, the function of gas exchange. The venules collect that capillary blood, they join into interlobular septal structures, they form the veins, and they join at the hilum of the lung. But the lung has a second circulation. It has a blood supply that comes from the aorta, and these are called bronchial arteries. And the bronchial arteries do not, in fact, as clearly travel with the airways, or they're smaller, at least by the time that they are seen, so they're not the sort of paired structure of airway and vessel that we say, and which I'll show you in a minute. They're smaller arteries, and they end somewhere at the end of the conducting zone of airways. And their function is to actually provide the blood supply to the bronchial tree, with the assumption that a lot of the distal lung parenchyma is getting oxygenation directly from, or is getting a blood supply and oxygen directly from the pulmonary circulation. And here the venous drainage is to the azygous and hemiazygous veins. And so this is a typical bronchiole and vessel, which we'll refer to as that bronchovascular bundle. The vessel and the airway are about the same size, and this is therefore an artery that is branch derived from, ultimately from the pulmonary artery. This is not the bronchial circulation. These smaller vessels around an airway may represent branches of a bronchiolar vessel, a bronchial vessel, I should say. When we look at an artery has a defined structure. This is the intimal layer. These are endothelial cells. This is some intima. There's an elastic layer. There's smooth muscle, another elastic layer, and then some connective tissue. So this is called adventitia. This is called media, and this is called intima. And the media defined by the muscle layer between the elastic membranes, and that's in fact a type of muscular artery. Now, as I mentioned, here the airway and the vessel travel together, and this eventually divides and forms the capillary bed that's in the alveolar space, or that's in the alveolar wall. Those vessels collect on the venous side, and the tributaries of veins collect in these interlobular septal structures. And so these are veins because they sit in that interlobular septal structure. And while veins have endothelium and they have muscle and they have some adventitia, they don't have that defined structure with the elastic tissue. It's a little bit less evident. And so you recognize veins based upon their location and that structure, or that lack of structure. In addition, in the interlobular septal structures, there are lymphatics. Lymphatics responsible for picking up fluid and bringing that fluid back into the circulation, ultimately collecting in the thoracic duct. And so these are all the vascular structures that are present within the lung. Here's an example of a section of gross lung. You can see not pink at all. This is someone who actually, no doubt, was a heavy smoker, and therefore the lung parenchyma has this brown-black color. But I haven't put that here for that reason. In fact, all the white lines that you're seeing are the lymphatic structures in the lung. And so they do have this path of following interlobular septa around bronchovascular bundles, eventually in the pleura. The reason that they're so thickened and white is that they're filled with carcinoma cells. And so this is known as lymphangitic carcinomatosis. But nevertheless, the purpose of this picture is to highlight the lymphatic structures. Lastly, pleura. Pleura is a membrane that is composed of a mesothelial lining and some connective tissue. The connective tissue is a mixture of collagen and some elastic tissue. And this is essentially the lining of your body cavities. So the spaces in your chest around the lung, which are the pleural spaces. The abdominal space has, in the peritoneal space, lining by these cells as well. And the function is, at least in part, to allow for sort of the smooth expansion and contraction of the lung. I suppose it actually, being that it lines the last line of alveolar sacs, is also containing the lung and preventing air from going from inside the sacs into that space. And you'll learn more about that in the respiratory physiology of why you don't really want air in that space. So during the part of the histology discussion, I talked about the airways. I talked about the function of the different portions of the airway, the delicate gas exchange portion, the epithelia, and the vessels that are in that portion. And now we're going to spend a brief time just talking about embryology and really focused in on what goes from immaturity to maturity and then what are the outcomes of some interruptions in that normal development. So the first thing I want to focus on is the separation from the alimentary and the respiratory tract. So laryngeal development occurs around week 4. There's a primordial respiratory bud that occurs in the distal caudal pharynx at week 4, known as the laryngotracheal groove. The larynx, it has an endodermal derivative of the epithelium, and this eventually buds and forms the trachea and bronchi. The connective tissue of the trachea and bronchi come from a splanchnic mesenchyme that surrounds the foregut. And so this is somewhat of a concerted growth between a mesenchymal cell and an epithelial cell that occurs in the function of budding. So in the course of the formation of the proximal larynx, there's a tube that forms. There are these, again, buds and growths that come up towards the tongue, which actually closes the airway off at that point of development. Eventually, that recanalizes. However, in some instances, there's a vestige of that structure that did not completely go away. And so laryngeal webs are an example of incomplete recanalization. Now, if that occlusion does not resolve, that is, that the larynx doesn't form or remains occluded, the lungs don't form properly. Because it's critical for lung development to occur in a liquid environment. There must be swallowing of amniotic fluid, and that has to get into the lungs in order for them to develop in utero. Now, in contrast, that fluid is really bad once the baby's born, but in utero, there must be fluid. If there is no fluid getting into the lung, either because of a neurological problem that prevents swallowing or because of physical obstruction, the lungs will not develop. We call that hypoplasia. Okay? So that will not allow for lung formation. Now, During laryngeal development, again, it's all a series of outpouchings and ingrowths. Those ingrowths are then invested with a mesenchymal cell, and a septum will form, and that septum is what eventually divides one tubular structure from another. And this diagram is meant to show you that you start off with a tube, in this case the pharynx. You have a diverticulum or outpouching. That diverticulum gets invested with mesodermal cells and grows and elongates. But at the same time, this piece right here has to not grow, or has to grow in order for there to be two different tubular structures. Otherwise, you would have just been essentially blowing up a balloon and making one big space. So essentially, you have budding and you have septum formation that allows for the laryngotracheal tube, and then here now the first division into the bronchial buds. And looking at it from above, again, these two are fused at one point, but that septum has to form and eventually allow for two different tubes to be present. Again, I went into detail here because this doesn't always occur properly. And so when those two tubes are not properly separated during development, a persistent connection can occur between the trachea and the esophagus. And those tracheoesophageal fistulas, as you look at the path by the arrow, you can see that some are problematic in that food will go directly into the lungs, causing aspiration after birth. Others simply don't allow for the proper movement of food into the GI tract, or as you can see, there are all different versions of where the fistula takes place versus the atretic segment. So now we're going from what's essentially upper airway development into the actual development of the lungs. By 28 days, which was the 4-week time, we have those buds and the splanchnic mesenchyme getting together into those early tubes. By 35 days, you can already recognize second-degree bronchi with recognizable upper, middle, and lower on the right and upper and lower on the left. By 42 days, you can already recognize those bronchopulmonary segments that I mentioned before, 10 on the right and 8 to 9 on the left. So this is already developed by 42 days. However, it doesn't look so recognizable in a way because these just look like a series of tubes and buds, but nevertheless, that part of the conducting airway has already started to form in terms of its basic structure by that time. At 9 weeks, actually a lot of organogenesis has already begun. And when we look at a cross-section of a 9-week embryo, we can see that there is an oropharynx already. There's a larynx. You can actually see parts of the larynx and the laryngeal cartilage in here. And you can actually see the alimentary tube already, the trachea, and lungs, and now into the GI tract. This is my early attempt at tile images before we had whole scanning, whole slide scanning. So again, all this is formed. So organogenesis at 9 weeks is largely, at least in its basic form, developed. But the lungs, if you had to say, if you took adult lungs and you took out the components that were mature, what you really have done here, in a way, is you're looking at lungs in which there are no alveolar sacs, there are no bronchioles at all, they're just primordial large airways. So you can imagine that at 9 weeks, there's no gas exchange capable in these organs, right? There's just no zone. And these structures are this combination of epithelium and mesenchyme, as I mentioned, and these undergo a series of branches. And so these stages have been defined, and there's a lot of detail on this slide, and the main thing I want to tell you is that you go from an embryonic point to where organogenesis is recognizable, as they say, to a pre-acinar level. Then you can start to see at between 16 and 26 weeks the recognition of the pulmonary acinus, meaning the respiratory zone. By 24 to 38 weeks, you can see them as more alveolar sacs. Essentially at term, the sacs are well-formed and capable of gas exchange. And alveoli continue to form, actually. It says birth to 3 years postnatal, but actually even to year 7 and year 8, there are still new alveoli being formed. So the pediatric lungs have fewer alveoli than adult lungs. So if we look at these stages, we can define them into essentially the period of time in which the airway branches, and with each branch, the part before it starts to mature. So you've got primordial bronchioles, Then you get respiratory bronchioles. The bronchioles mature. The respiratory bronchioles are there, then the alveolar sacs are there, and the respiratory bronchioles mature. And so at each branching step, there's division, growth, maturation, and the leading edge is continuing to divide and divide and divide, all of which requires a liquid environment. That being said, somewhere, and oddly, if you thought about it at first, you would think, well, why don't you make the vessels divide at the same time as the airways? I mean, you're sort of dividing anyway, right? But that's not how it happens. The vascular ingrowth happens afterwards. And so that is an interesting reality that actually while the airways form and continue to divide, the vascularization occurs afterwards. And so that's another thing to keep in mind, that the airway branching and branching morphogenesis happens first, and the capillaries grow in later. Again, when you're thinking about when lungs are actually mature and capable of even performing rudimentary gas exchange. And so look at those dates and look at those times, and you'll begin to understand why 24, 25 weeks is really a critical time in terms of immaturity and supporting gas exchange after premature birth. Okay, so again, just to scroll through, these are lungs in that very early stage where they just look like glands, but you can already make out that the glands are getting smaller than in the 9-week picture. Here you can recognize that there are bronchioles and sacs, but again, the sacs are way too cellular. You don't have that nice thin membrane yet. That's at 22 weeks. At 31 weeks, you can recognize bronchioles. You can recognize the transition from the conducting portion to the respiratory portion. They're a little bit cellular, but still gas exchange can begin to take place at this point. But you can also understand why these lungs are still immature, even physically. They're not the same as the normal adult thin membrane. There are other factors as well. The surfactant being produced at this point is not the same as the mature postnatal surfactant. So there are other chemical reasons, but even physically, the lungs still look immature. And then finally, the alveolar walls, the bronchioles of the lung at birth, which is very similar to adult lung, a little bit more cellular, and as I mentioned, fewer alveoli than there are in the adult. So, we talk about developmental anomalies and immaturity. Well, cystic aneuploid malformations represent a maturation arrest that occurs in sometimes a focal lung segment of development. And so it's presumed, well, at least one such thing is definitely the case, that an airway becomes obstructed, sometimes because the bronchus leading to it is in some way atretic or abnormal. And so once that happens, the lung distal to it, no longer getting fluid, stops maturing. And so that whole segment of lung will still look like fetal lung. And depending on when that occurs during development will depend on just how mature or immature that lung will look distal to that obstruction. And these cystic aneuploid malformations are diagnosed now in utero. Sometimes they resolve by themselves, but sometimes they require a surgical excision in order to remove them, because they can be a source of infection or problems later. Again, the location of the lobes, although determined so early, nevertheless, there are some times where one gets, again, variation on the theme. And there are also what we call sequestrations, which are pieces of lung that somehow become disconnected from the tracheobronchial tree and parasitize circulation from either the diaphragm or the chest wall. And so again, the idea is that all these things happen, and they happen in a concerted way, but occasionally there are malformations. Here's an example of term lung alongside one of these cystic malformations, and you can see congenital cystic aneuploid malformations, for those who want to know what the abbreviation is. And you can see that these look like bronchioles. They look like the lung that I showed you perhaps in the canalicular phase. They're not normal alveoli. Again, obstruction occurred in this lobe during development, preventing fluid from getting in and allowing proper branching. So breathing is, while not breathing of air, the exercise of breathing allows that branching to continue. It does begin prenatally, and that fluid that's in the lung during delivery is expelled from the lungs into the capillary and lymphatics due to the course of the baby coming through the birth canal. That fluid is absolutely critical for proper lung development. Insufficient fluid leads to decreased lung development or hypoplasia. Insufficient breathing movements result in decreased lung development as well, but as a neurological cause. So you can have physical obstruction, you can have neurological reasons.
How is the
certainly there's still physical pressure that happens, but it's certainly part of what naturally occurs to allow that to happen. But again, that physical pressure is still enough. I mean, the space during a C-section is still confined, and that's enough to expel fluid. That being said, there could be a lot to discuss there in terms of the benefits of one type of delivery over another, but nevertheless, enough happens that fluid will come out. Now, certainly, fluid in the lungs is one of the early problems, postnatally after birth, and so certainly there are issues there as well. Again, oligohydramnios or insufficient amniotic fluid will cause hypoplasia of the lung. Again, not enough fluid in the not enough amniotic fluid, not enough lung development. Or compression. If there are intestinal contents that are now in the chest because the diaphragm is not normally present, which is a congenital diaphragmatic hernia, so you have an intestinal loop now in the thorax, that lung may not develop normally because there's pressure that prevents fluid from freely going into that lung, and again, intrathoracic fluid or a thoracic wall abnormality can all cause hypoplasia of the lung. Now, this is one slide that covers a lot of territory, and it is probably my last slide, but understand that the lungs are immature. They're immature physically, and they're immature because, in fact, the surfactant proteins that are normally present at the adult time are not present at that point or are not present in the same composition at that point. That surface tension the reduction of surface tension that surfactant allows for is really what allows lungs to expand in air environment. And so inadequate surfactant leads to collapse of the lungs, and that, again, the difficulty in reinflating those lungs is part of the lung disease of prematurity. A similar thing you could argue happens in adult ARDS, but here we're going to talk about RDS, or the respiratory distress syndrome in infancy. The ventilation that is required in infants can cause lung injury, and that's called bronchopulmonary dysplasia. And in order to prevent that collapse, there can be things given during a premature birth to accelerate lung development, to accelerate the maturation of surfactant, and even to give surfactant to allow lung expansion. So critical point is from development to breathing outside of the uterus is really this conversion from a fluid environment to an air environment. And another thing which we didn't talk about much because it's probably more covered or more appropriately covered in cardiology are the vascular changes that have to occur as well at that point. But that's not so much covered in this course. And with that, I thank you very much for your attention. And if there are any questions, I'm open.